Welcome, everyone. Thank you for joining us. In this session, we'll be sharing with you our journey in addressing the transitions of care from the acute care to the community for one of the most vulnerable population in our society, people experiencing homelessness. We hope we can provide you with some insights that you can take back into your environment, and we hope to learn from your feedback for our session. So I am Sogata Chakraborty, and I'm joined by my colleagues Jennifer Lee and Sarah Mikhail. And our narrative will cover a brief overview of our healthcare system, a portrait of a typical client experiencing homelessness, who we will from now on refer to as the no fixed address client, and finally, a little healthcare system data on the current state of hospital readmissions that catalyzed the design for change. And we will end with the feedback for the users of our design and the reflections as we move forward with this project. We would like to start off with a visual of Canada geese flying in formation, which we feel is a perfect metaphor for our work. The lead goose sets the tone, and the followers have to constantly adjust their formation for an energy-efficient journey to their final destination. For our purpose, the lead goose is our no fixed address clients, with their care providers arranging themselves effectively to provide for a holistic and efficient care journey. Before we get into the weeds, here is a brief description of the two systems that a no fixed address client, person experiencing homelessness, regularly interacts with in their journey. We have the Alberta Health Services, which represents the single health authority in the province that delivers a majority of the medical care through 400 facilities across the province. That includes hospitals, public health clinics, and continuing care facilities. We are located in the city of Calgary, and here's a snapshot of the population in Calgary and the Calgary homeless population by comparison. As you can see, it's only 0.2% of the entire population, which is indicative of the decade-long hard work that the community social supports have put in to reduce homelessness. But there's still a lot more work to be done, especially in the areas of transitions of care. The second system that a homeless person faces is the multiple community social supports that accounts for shelter and the care of the homeless in the community. As you can see, the system is large and complex, but when navigated properly, it provides multiple ways to support NFA clients. So how does an NFA client experience these two systems? For that, let's take a walk with Jerry. Or take a walk in Jerry's shoes, excuse me. So here is Jerry. He's a 40-year-old man experiencing homelessness. He has severe skin infection and suffers from ADHD. Every time he leaves the hospital, he loses his discharge papers. That tells him what to do when he leaves the hospital. When he leaves the hospital, he is back again at the Foothills Medical Center Emergency Department, and once again he has lost his papers. Now meet Ellen, Jerry's social worker, who knows Jerry very well and understands his predicament, but is at a loss to help him outside her acute care bubble. She needs to figure things out, but she lacks perspective of what happens to Jerry in the community. As she's trying to figure things out, she gets the message that hospitalist Adam is preparing to discharge Jerry the next day at 9 a.m. This leads to Jerry's nurse, Anna, hurriedly trying to prepare his discharge papers. And she's concerned about what would happen to Jerry once he leaves the hospital doors, but has no time to figure out what that would look like as she's busy preparing his discharge papers. Now, Jerry leaves hospital the next day. But in a few weeks, he shows up at the community shelter nearest to him as his infection is getting worse. Community nurse David knows Jerry very well too, but since Jerry has lost his papers again, he cannot articulate what treatment he has received in the hospital. And so Nurse David cannot provide the appropriate care for him, and he ends up sending Jerry back to the Foothills Medical Hospital. So this is the current state of transitions that usually happens, and it's a challenge that occurs frequently enough to be identified as an opportunity for improvement. So, as you might have surmised, there is lack of cross-sectoral perspective between acute care and the community. Each provider in these sectors have no idea of what the other providers go through in the other sector. We found that information flow is siloed due to the privacy culture and use of different technologies to handle patient data between the sectors that don't talk to each other. So to address this opportunity for improvement, we picked a site which was most impacted by this situation, Unit 61 and 62 of the Foothills Medical Center, who frequently admits NFA clients like Jerry. We gathered a team of nurses and social workers who are highly patient-centered and motivated to do something different. We've picked a few community paramedics as well, as they're the most familiar with NFA clients and are able to meet them where they are at outside of the health system. And finally, we managed to collect a few frontline providers from community care organizations such as the Drop-In Center, Alpha House, and the CUPS. We brought this team together to ideate on the project challenge. But to ensure that, to design for the change we want to see, we have to rally folks around a common purpose. Our co-created purpose, our reason for getting together was to ensure that no fixed address clients receive quality care supports that maintain good health across their care continuum. Our actionable vision to embody the essence of our purpose is to start by making the present transitions of care from inpatient to the community as seamless and patient-centered as possible. But how can we address that vision? We reframed our vision in the form of a challenge question, which is how might we inspire communication during admission and discharge that facilitates an intentional client transition between acute care and the community. But before we started the brainstorming, we needed to gain insights to the current data that exists that might help inform us on the metrics we need to come up with for testing our design prototype. Here is Jennifer with the data part of the session.
So just to give you a quick snapshot of the data from the Foothills Medical Center, we pulled data from 2019 specifically for this presentation. And so if we could go to the next slide, what we found is that in acute care, on average, NFA clients are currently staying for 11.9 days. And when we compare that to the expected length of stay, it's 8.5 days. So we can conclude from this snapshot that NFA clients on average are staying at the Foothills for longer than expected. And then on the next slide, what we found also is that when we look at the top 5 diagnoses for NFA clients in 2019, the top diagnosis by far is mental and behavioral disorders due to psychoactive substance use, followed by schizophrenia, schizotypical and delusional disorders. And then rounding out the top 5, we've got skin infections, head injuries, and influenza and pneumonia. And so that just gives you a quick profile of the types of clients that are coming into the FNC. So how do we go about designing for change? And so what we started with, and this is a quick overview, is a design thinking sort of methodology. And so that begins by doing interviews with providers and clients in acute care and community. And after those extensive interviews, we mapped their journeys so that we could understand what the flow and the client experience was between acute and community. And from that map, it gave us an understanding of what the primary pain points in transition were. And so then we brought all of that information to a group of representatives from acute, community, and community paramedics. And we asked them to discuss, to digest that data, and then finally to decide what they wanted to work on, and then come up with a solution. And so from that solution, we then create what's called a prototype, and then we go ahead and test it. And so our origin story is summarized on this slide. Our stakeholders wanted to work primarily on communication. And so then they designed a form or envisioned a form that could be used and filled out by both acute and community providers. And this form would travel with the client throughout their journey in the two systems. But when we went out and tested this form, what we discovered is that it did not work in either environment. And so then we moved to a process after thinking and discussing with our stakeholders. And so we took this process and we tested it extensively and incorporated feedback with each successive test and iterated it all the way through. And then we had an opportunity to test with 5 live clients. And from that live testing, we learned a couple of things. The first is that we had to develop an alternative process if the client left acute care against medical advice. And so we built that into our process. The second thing is that the face-to-face meeting with one of our key stakeholders, the community paramedics, was really important for building trust and rapport. And the final learning is that community paramedics, as an AHS provider that moves between acute and community, had to facilitate the transfer of information to any community providers that were involved. And so this is our process after all of that testing in current state. So number one, when the client is admitted to the inpatient unit, there's a immediate referral to our community paramedics providers, and they have expertise in the homeless sector here in Calgary. And so they're very specialized in this area. Number two, that referral goes out, is accepted, and then there's a face-to-face meeting with the client, the acute care team, and community paramedics. And as I mentioned before, that was very important for trust. And also allows the acute care team to leverage any expertise that community paramedics might have. They're then coordinating with the acute care team throughout the client's inpatient stay and helping to advise on the discharge plan. Community paramedics is also pulling in any community providers as they feel is appropriate. Step 4 is at the point of discharge, there's a warm handoff between acute care to our community paramedic team. And then community paramedics team is facilitating transfer of information to any providers that might be involved in the community. And that is step 5. And so we tested this process and got quite a bit of excellent feedback from it. So I'll pass it over to Sarah to review that with you.
Thanks, Jen. We just wanted to take some time and share some of that feedback that we received from our stakeholders, because our quotes we think are pretty epic. So the first one that we would love to share with you is from the community paramedics team. They thought that meet and greet that Jen was talking about was a massive game changer. It was an opportunity to build rapport, and it was really the first time that all of these stakeholders had been in a room together. The second group was from Acute Care. So they thought that without this project, we'd essentially be going back a decade in our work. There's a desirability to definitely keep going. And this project gives an opportunity for us to create a plan and actually have connections between sectors. We often describe these sectors as megaverses because they're enormous and they're faceless to the opposite team kind of thing. And so this was the first time that they knew who to contact. You know, it's Jen at the drop-in center. And the community felt that it was very positive as well. This was what they were seeing is clients would exit the hospital, and then all of a sudden, all those health progress that we'd made and seen would just take a huge step backwards. And so now it increases the likelihood that the client will have good health moving forward. And so they're very, very excited to see this project moving forward, which is what we would love to do as well. And so as we take some time to as we took some time to review what we did and the opportunity to move forward, we wanted to look at our progress through this lens of the quadruple aim, which is AHS's adapted form from the Institute of Health Improvement. So the first thing that we like to look at is the patient experience first and foremost. We want to make sure that patients have clarity on what it is that they need to do to maintain their positive health after leaving hospitals. We want to make sure that they understand who it is that they need to be connected to, and that they understand what they need to do next. And most importantly, especially for this population, having been heard and listened to and really feeling like their needs were met was our top priority. The second thing that we look at is the population health overall. So what we were seeing is that clients were leaving hospitals and weren't filling their prescriptions, and they weren't attending any follow-up appointments. And so this project really mitigated that for the test population that we worked with. It allows us to connect to their primary healthcare physician or their nurse at whatever shelter they frequented, and honor the requirements of the hospital and make sure that they had an opportunity to follow up on it in a holistic manner. The third, of course, is system cost reduction. This population, despite how small it is, as Shogi mentioned, is quite expensive on our healthcare system. And it's always important for us from a systems perspective to mitigate costs as much as possible. So that means reducing readmission rates, reducing our inpatient days in the hospital, and also reduction of inappropriate emergency service use, such as paramedics and the emergency department. And finally, we wanted to check in about our provider experience for acute care and community. And so that means looking at surveys and interviews for these populations to ensure that their compassion fatigue is not sucking them dry, and that they're actually able to continue to do this work, and they feel connected and supported by other systems in our care. And part of our future focus reflection is looking at rose, bud, and thorn, as we like to call it. So it's this taking a look at our wins and successes, our opportunities and areas of growth. And I'll start us off by taking a look at our small wins and successes, which include that initial interview journey and mapping gave us a holistic understanding of what's going wrong. This has never really been done before, and it was the first time we were able to share what we thought was common language and understand what it actually meant to the other team. Designing methods to ensure active involvement in service providers. Not everybody had been engaged before. It was always either something from the homeless serving system of care or from Alberta Health Services. And so we created an opportunity where everybody had a voice and everybody could create a big picture solution. And the clients who participated in the test run did do actually quite well. And we were, of course, thrilled to see that, since that was our primary objective. And we'll pass it on to Shogi for the buds.
Yeah, and we are very, very excited for the future, mainly because initially it was hard to get the hospitalists on board, just because they were very busy in general, taking care of patients, but they have warmed up to the project and want to take an active part. It was heartening to see that there was continued motivation among executive leadership team to keep going with this project, despite the caveat of the COVID wave hitting Calgary. And finally, as we do more of these interviews and we gain a better understanding of the challenge faced by the providers in their individual environments, and that makes the development of the prototype much more geared to their needs. And I'll turn it over to Jennifer for the challenges.
So some of the challenges as you can imagine, is coordinating between two very complex systems, the health and the homeless serving sectors of care. We feel that we're continuing to narrow the gap between these two very complicated sectors, but there are silos that continue to exist. And we also found that one of our primary challenges that was completely unplanned for was COVID-19. And so the pandemic has shifted the ways of working in both sectors. And so we expect that we're going to have to adjust our transition process to sort of accommodate the new realities. And so that is our presentation. We thank you for your time and we welcome any questions that you might have.